Good morning, everybody. Thanks for coming to Grand Rounds. I'll turn it over to Dr. Jordan to introduce our speaker.
Good morning, everyone, and welcome to Grand Rounds. It's my pleasure to introduce today's speaker, Dr. Juan Wisnivesky. Juan Pablo Wisnivesky is the Doctors Richard and Mortimer Bader Professor of Medicine and the Chief of the Division of General Internal Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Wisnivesky is a health services investigator with a research interest in chronic pulmonary disease self-management, lung cancer outcomes, and disparities in care. He received his MPH and Doctorate of Public Health in Biostatistics at the Joseph L. Mailman School of Public Health at Columbia University, and his MD at the University of Buenos Aires School of Medicine in Argentina. Dr. Wisnivesky has received multiple grants from the National Institutes of Health to support his research, and he directs a federally funded cancer prevention and control training program focused on underserved priority populations. He has published several manuscripts addressing issues related to lung cancer epidemiology, asthma, COPD, and more recently regarding the post-acute complications of COVID-19 infection. His research has unveiled the rates and underlying reasons for disparities in lung cancer care and has shown that lung cancer has a more benign progression in women, suggesting biological differences in behavior. He has used novel statistical tools to answer key questions about lung cancer treatment in older adults, which have been incorporated into clinical guidelines. He has mentored and trained dozens of medical students, residents, fellows, and junior faculty, many of whom have moved to independent research careers and academic leadership roles. More recently, he has been directly involved in the institutional efforts to understand the long-term consequences of COVID-19 infection and is leading the Mount Sinai COVID-19 registry. He is also one of the principal investigators for the Mount Sinai Site of Recover, an NIH-funded initiative to learn about the long-term effects of COVID-19. Dr. Wisnivesky is an active faculty in the American Thoracic Society's MECOR program and was appointed to the coordinating committee for the National Heart, Lung, and Blood Institute National Asthma Education and Prevention Program. He is also the chair of Health Equality Committee of the American Thoracic Society and a member of the American Society for Clinical Investigation. Please join me in welcoming Dr. Juan Wisnivesky.
Well, good morning, everybody. Thank you, Jordan, for that very kind introduction. I'm going to talk today to you about early stage lung cancer, and as I want to try to make an argument why focusing on early stage is the only way to really achieve better long-term outcomes in lung cancer. Sorry. So these are my conflicts, but should not influence the talk. So why this talk is important? Because as you probably all know very well, lung cancer is one of the most common cancers, both in men and women, but more importantly, is the most common cause of cancer death, with 1 out of 5 cancer deaths in the US today being due to lung cancer. And outcomes in patients with lung cancer is relatively poor. And this is because almost half of patients are diagnosed with stage 4, which has a 5-year survival of only 15%. And only 20% currently are diagnosed at early stage, the only stage that conveys some meaningful long-term survival of around 65 to 70%. Unfortunately, as I will make the argument later, most of the research currently in terms of funding, both at the federal level and in terms of pharma, is focused on advanced stage disease. And, I think that this path is unlikely to take us to better long-term outcomes. So in this talk, I want to talk a bit about screening for early lung cancer detection. What is the current status? How we generate the evidence to determine the optimal treatment for patients with early disease. And finally, what is the path for equitable diagnosis and treatment of lung cancers to ensure that everybody achieves similar outcomes. So in terms of lung cancer screening, the modern era of lung cancer screening started with this seminal article that was published by Dr. Henschke in the 1990s. She is, as you know, in this institution now, showing that when you do low-dose CT screening, an observational cohort of 1,000 patients, most of the patients are diagnosed at early stage with small tumors around 1 centimeter, and that is a striking contrast when you see in clinical care, with approximately, as I say, 50% of the cancers are diagnosed at late stage. So this opened the door for the possibility of low-dose CT screening being a path for early diagnosis. And since then, we have two large randomized controlled trials of lung cancer screening, the NLST in the US, which randomized more than 55,000 patients to chest X-ray versus low-dose CT, and the Nelson trial in Europe, which randomized, around 70,000 patients to low-dose CT screening versus, usual care. And both studies show similar results, that after, low-dose CT screening is associated with a reduction in lung cancer mortality of around 20 to 25%. And this is pretty conclusive. Based on this data and some work, simulation work, led by several groups, including Dr. Icahn, which is in faculty at our institution, and led to the United States Preventive Services Task Force to issue a recommendation in favor of lung cancer screening. And the current criteria are that any adults who are 50 to 80 years of age, who had smoked at least 20 pack years, and are current or had stopped smoking less than 15 years ago, should be candidates and should be recommended low-dose CT screening. So how are we doing in terms of implementations? Well, unfortunately, things that here are not so rosy. Although this is national data of the percentage of the population that are eligible for screening, who receive low-dose CT, and you see that, since the recommendations were issued, there's been some uptake, but still rates of screening are really low among those who are eligible. And this is striking comparisons with, other screening tests that have been around for longer time, such as mammography or CRC screening, that are close to 70% of those eligible. So plenty of work to do. Another interesting issue is how we optimize the criteria for selecting who should undergo screening. As I mentioned, the current recommendations are to determine who should undergo screening based on age and smoking history, and that's the entire data that is used. Since then, there's been several different approaches. One here shown in this study published in the New England Journal of Medicine, where investigators use established index to determine risk of the probability of dying for lung cancer, and then divided the NLST population according to quintiles from the highest to the lowest risk of developing lung cancer versus your smoking history, but other characteristics. And what they show is that if you focus screening on the first 3 quintiles of the higher risk, you achieve 88% of the mortality reduction that you will achieve by screening, the entire NLST population. And you see how, this impacts the number needed to screen, where you screen the higher risk patients, you only need to screen 160 patients to save 1 life, compared to over 300 when you screen the entire cohort, suggesting that really we can do a better job at, selecting who should be undergoing screening. We were also interested in assessing, can you use information from your CT and risk factors, extracted from there to further assess who needs follow-up CTs, because remember that the current regimen screening is that you use an annual CT from age 55 to 80. So if somebody that you start screening at early age, you may have 25 years or 25 years of screening in the future. So in this study, we were interested in looking at the information in the baseline CT regarding the presence of absence of emphysema. Emphysema, in some work that's done by Javier Zulueta, which is also faculty at the department in Spain, showed that was the first to show that emphysema is an independent risk factor for lung cancer. So in this study, which was led by a medical student, we looked at those patients in LST that have a negative CT at baseline or at 1 year follow-up. So these patients, around 20,000, should continue to undergo CT because the baseline CT is negative, but they're still at risk of lung cancer. And we use 3 validated models to estimate the risk of lung cancer based on all the information that we know is predicted for lung cancer. And then we evaluated how much emphysema adds to that and how the presence of absence of emphysema influences the number needed to screen to identify one lung cancer. So first, I'm showing you here whether emphysema contributes to the risk of lung cancer independent of these prediction models. And here you have patients, the cumulative incidence of lung cancer over time, according stratified by the quintile of lung cancer risk based on the prediction model, from the lowest in blue to the highest in red. And here we're comparing for each quintile, those who do not have emphysema versus those who have emphysema on the baseline screening CT have much higher risk of developing lung cancer. Additionally, we look at the number needed to screen. And this is according to the risk quintile based on this model or other models below. So as you can see, among those who have a negative baseline CT, the number needed to screen in general is 166. You need to screen another 166 patients to detect one lung cancer. Where if you have 2 negative CT, the number goes up significantly as expected. These patients have gone twice through screening and have no lung cancers. But more importantly, those emphysema really impacts the number needed to screen. Those without emphysema, you need to screen more than 360 patients to identify one lung cancer, compared to those with emphysema that among those you need to do only 86 screening tests to identify one lung cancer. Again, suggesting that we can use the information from the presence of absence of emphysema on the baseline CT to further determine how to follow up these patients in the next years. Stacy Brown, which was a fellow and then a faculty in pulmonary here, was interested in looking at the predictive value of interstitial lung abnormalities. This is because we know that asbestosis and IPF, which are fibrotic diseases of the lung, are associated with the risk of lung cancer. However, many patients have these small areas of increased density on the CT, which in patients without interstitial lung disease, which are otherwise asymptomatic. And we didn't know at that time whether these small CT findings were predicted of the presence of lung cancer on additional screenings. So she also used data from NLST. She included around 25,000 patients in the CT arm. And we found first that approximately 20% of the participants, which again, were asymptomatic and had no history of interstitial lung disease, have these interstitial lung abnormalities. But more importantly, those who had, this is the cumulative incidence of lung cancer over time, those who have interstitial lung abnormalities have a 60% increased rate of lung cancer on follow-up. Again, suggesting that this is an independent risk factor for lung cancer first, but also is another piece of information that we can use to target patients at increased risk for lung cancer, which should continue to undergo additional CTs. Finally, another evolving area is the potential of using biomarkers for lung cancer screening. There are varied types of potential biomarkers that have been tested and developed, including antibodies, proteinomics, liquid biopsies, Excel condensate, et cetera, et cetera. Recently, we got a grant from the Longevity Foundation to do a simulation study to understand better what could be the potential role of biomarkers in this setting. And these are some results of the simulations that Dr. Icahn did with the model that we'll speak a bit more about a bit later, where here we're evaluating. We are comparing the current strategy of screening based on the USPSTF recommendations versus a biomarker that will be applied for all smokers. So here you will, anybody is smoker, you undergo this biomarker. If the biomarker is positive, you undergo CT screening and further workup. And we assume that we were working with a biomarker with a specificity of around 85%, and we wanted to see how the sensitivity affects the benefits of the potential benefits of the biomarker. And you can see here, this is a mortality reduction based on the USPSTF criteria for lung cancer screening, and a biomarker that has over around 60% sensitivity will perform better than the current criteria. Again, suggesting that this work can allow you to find the right group, where these biomarkers should be deployed, also which diagnostic characteristics of the biomarker are needing for adding them to the current screening criteria and improving survival of patients with lung cancer. So let me switch gears a bit and go from screening to treatment of lung cancer. And this is because just identifying early cancers is not enough. Obviously, you need to treat them effectively and early, therefore, so these patients can achieve good outcomes in the long term. And in terms of lung cancer treatments, the two main strategies currently are surgery and SBRT. And surgery could be, in terms of techniques, could be performed in three ways. You can have a lobectomy, which is the full resection of a lung lobe, a segmentectomy, which is a resection of an anatomic segment, but not a full lobe, and a wedge resection, that is anatomical resection, is a non-anatomical resection around the tumor. And this can be performed both through open surgery, which is the older technique, through video-assisted thoracoscopy or VATS, and then more recently through the different types of resection, and then SBRT, which is a radiotherapy technique that uses high-dose radiation in limited number of fractions, 3 to 5 fractions, to treat very concentrated around the tumor. All right, so what is the evidence supporting these treatments for early-stage lung cancer? As I mentioned before, if you look at late-stage disease, these are the number of new immunotherapy and targeted therapy for advanced disease have been approved in the last few years based on large phase 3 RCTs. Now, when you focus on early-stage disease, the picture is very, very different. These are all the different strategies that I mentioned as potential treatments for lung cancer, early-stage lung cancer. And we have few RCTs done in the mid-50s and 60s. I will share with you the results in a minute. And then it was a trial in the 80s of limited of sublobar resection versus lobectomy, and then nothing else. All these new treatments have been adopted in the last 20 to 30 years and been rapidly implemented, have not been tested in randomized trials. These are the trials that tested surgery in the 50s, which is now considered the standard of care for early-stage lung cancer. No doctor will doubt that if you have a patient with small lung cancer, this patient will do the best with surgery. Now, these studies compare surgery versus RT, and this we're talking about, very old RT that is very, very ineffective. And if you look at the results, patients treated with RT in these RCTs have worse outcomes, but they were not significantly different from surgery, suggesting that, there's no differences in the two treatments. Clearly, this is something that we don't believe these days, and we definitely agree that surgery is a treatment of choice, but, here is the evidence, what the decision is based to. And this takes us to this paper that was a real paper published in the BMJ, a few years ago, where these authors look at the evidence supporting the use of parachutes when you're jumping off an airplane. And they did a systematic review, and not surprisingly, could not find any RCT that randomized people to use of parachutes versus no parachutes. And they concluded actually that the evidence for using parachutes in this setting may be, biased due to a healthy cohort effect. What is the point here? They concluded also that individuals, physicians and individuals who insist that every intervention that we do is based on an RCT may need to come down to earth with a bump. Again, I'm not trying to make a point about RCTs. I truly believe that RCTs provide the best evidence for, our decisions. The point here is that in the case of, early lung cancer, as I showed before, sometimes we need to use other types of data because either RCTs are not feasible or, are never done. And therefore, how do we use other types of data to make informed decisions? And I'm going to spend the next few minutes showing you some of our work on that end. This is the only RCT that we have. This is a study done in the 80s, published in the early 90s, randomizing patients with stage 1 disease, means like tumors without lymph nodes that are less than 3 centimeters in size. And they compare lobectomy, a full anatomic resection of a lobe, versus sublobar resection. And they found that lobectomy was associated in one-sided test, which is a two-sided test, this kind of goes away, with lower rates of recurrence. But there was no significant differences in overall survival. However, since then, there's been a big shift on early-stage lung cancer. There were bigger tumors, mainly detected on chest X-ray, around 2 centimeters inside. And since then, particularly with the use of CT, we're diagnosing tumors at a much earlier stage. In this setting, we were interested in understanding whether, you still need to remove a full lobe when you have a tumor that is smaller than 2 centimeters, particularly in older populations who may have a more limited life expectancy and therefore lower chance of experiencing a cancer recurrence. We conducted this study using data from the SEER Medicare registry, and SEER is a national database that collects all new cases of cancer, including lung cancer, now from 23 regions, including approximately 30% of the US population. And from this registry, we identified over 1,000 patients with tumors less than 2 centimeters that were treated either with sublobar resection or full lobectomy. Clearly, the limitation in this type of analysis is what we call allocation bias. Some patients got limited resection, sublobar resections, because of certain specific reasons, like older age, more limited functional status. And those factors are confounders also of survival. So if patients with limited resection did worse, is because the surgery was the making the difference, or is because the factors that led them to have surgery were driving these differences in outcomes. An approach that you have to address this potential of allocation bias is the use of propensity scores. And let me just spend a minute tell you how broadly this works. In a randomized trial, you will take patients with stage 1 disease, which will be randomized 50-50 to have a lobectomy or limited resection. So every patient has a 50% chance of getting each treatment. And because these two groups are well balanced for covariates, you can do meaningful comparisons for survival. In the propensity score analysis, things work a bit backwards. You have observational data, patients with stage 1 disease, some that got lobectomy and some that got limited resection. And this was decided by their doctors at the time of presentation. Now, you can use this data to estimate a model, a statistical model that allows you to predict the probability of undergoing, for example, lobectomy for each patient in the cohort based on their baseline characteristics at the time of presentation, age, comorbidities, etc., etc. And hopefully what you have is a situation like that. Some of the patients that got lobectomy may have high probability of getting lobectomy because they were younger, they have limited comorbidities, but some patients that were older, more comorbidities, poor functional status, and therefore had a low probability of lobectomy, still underwent lobectomy. Similarly, you hope to find a similar pattern among patients who underwent limited resections. Some that have low probability of lobectomy, like this person here, but some that maybe were younger had a higher probability of undergoing lobectomy, but at the end of the day, they went limited resection. And what you can do is then start selecting for each group patients in pairs or matched patients that have similar baseline probability of lobectomy based on their baseline characteristics. And then you can keep doing that until you have a balanced cohort. Not everybody had the probability at each individual level is different, but overall the two groups are matched in terms of their baseline characteristics, and then you can do meaningful comparisons of survival or other outcomes. And this is what we did in this study, and we find that overall, for the entire sample of tumors less than 2 centimeters, limited resection was associated with equivalent survival. However, when we replicated the prior RCT and look at larger tumors, limited resection was associated with worse survival, suggesting that lobectomy is the better therapeutic approach. As I mentioned before, robotic surgery has been in the last 5 to 10 years, but I think more like 10 to 12 years, incorporated in the armamentarium for the treatment of early stage lung cancer. And as I mentioned before, also there's been no RCTs. So we also use this national registry to look at around 3,000 patients that underwent lobectomy via open surgery, video-assisted thoracoscopy, or VATS for early stage lung cancer. And first, we look at perioperative complications. And as you can see, robotic surgery did better in many outcomes, including, perioperative mortality and length of stay compared to open resection. However, there were no significant difference between robotic surgery and VATS, a more modern approach. When you look at certain lymph node dissection, which is a marker of good anatomic dissection and good staging, there was no difference between open surgery and robotic surgery or VATS. Similarly, in terms of survival outcomes, both open resection and robotic surgery or VATS versus robotic surgery were achieved similar outcomes. And this was adjusting for propensity scores and other types of matching. Finally, we compare cost, and in this case, robotic surgery in red had higher cost than VATS and a bit lower, similar cost to open surgery. And so in conclusion, this data suggests that robotic surgery really does not seem to lead to better outcomes than VATS. There is a well-established alternative and maybe more costly. And, suggests that we may need to look at this in a bit more detail before we, implement and adopt, robotic surgery as a standard of care for early stage disease. What about the evidence and the data for SBRT? SBRT has been, in the last few years, became the standard of care for patients, definitely with an operable disease, and is considered a potential alternative to limited resections for patients that may not be candidates for full lobectomy. And this graph shows the uptake of SBRT, how very quickly since the early 2000s has take up and replaced other forms of radiotherapy like 3-dimensional RT that were considered a standard treatment before SBRT. And this slide shows the randomized trials that have been attempted to compare limited resection surgery versus SBRT for patients with early stage disease. In the early 2000s, there were 3 trials that were started, with ambitious goals of recruiting between 400 and 1,000 patients, and they were all closed prematurely because they could not enroll patients. Since then, we have 5 new studies that started, 4 new studies. They are trying to recruit. There were no reports. I tried to obtain data in terms of how they're doing. I know anecdotally from the PIs of one of these studies that they were having challenges. And this trial that was started in England as a pilot study to show feasibility with a goal of 50 patients was closed after enrolling 24 patients, and their conclusion was that this study was not feasible. So this data combined clearly shows you that it is unlikely that we're going to have data from an RCT as to whether SBRT is an optimal choice for these patients. In the meantime, Nicole Esser, that is a Canadian physician that spent 2 years with us doing research, look again at the CR Medicare registry over 2,000 patients, and using this propensity score methods show that in general, when you compare SBRT to limited resection for patients with tumors less than 5 centimeters, SBRT leads to a little bit increased mortality, but not significantly different from limited resection. And the only group that did better with surgery were those patients who underwent segmentectomy, which had SBRT had increased risk of overall and lung cancer specific mortality compared to those that underwent segmentectomy. Again, here we're not compared to lobectomy, which is a standard of care. However, it's not about the number of years you live, it's also important the quality of life, of course. We got an R1 funding from NCI to take a deeper dive at patient-centered outcomes of patients treated with SBRT versus limited resection. So we did a 5-site study where we enrolled patients that had stage 1 lung cancer that were considered for SBRT versus limited resection, and we collected detailed data in terms of the presentation and the patient characteristics, include functional status and lung function before surgery, and then we follow patients with surveys at 7, 30 days up to a year. We are doing a survival analysis. We recruited around 387 patients, but this was in the middle of COVID, and our hope was to recruit a bit more patients. So we will need to do later follow-up. We have linked this data to the National Death Index, and we'll be looking at survival outcomes down the road. But in the meantime, we look at adverse events and quality of life after these procedures. And in this recent paper, we found that SBRT was associated both at 30 days and 3 months with increased rates of constitutional symptoms like fatigue, tiredness, sleepiness, etc. However, surgery, not surprisingly, was associated with increased rate. Here is SBRT versus surgery. So SBRT was associated with lower rate of respiratory or infection complications, which is expected because these are all relatively high-risk patients which are not candidates for lobectomy. In terms of quality of life, here I'm showing change of scores from baseline. Patients with SBRT had limited impact on the physical domain of quality of life over time, from 7 days to 12 months post-treatment. However, the surgical group took an early hit and had a significant decrease in quality of life. However, importantly, by 3 months, it was back to whatever the baseline was and similar to those with SBRT. In terms of mental health related quality of life, there was limited differences and most groups remain stable. And so this, I think, shows important data suggesting that it's true that surgery in these patients may be associated with an early increased rate of adverse events and poor quality of lives. However, this seems to be relatively transient, and we do not see long-term impacts from surgery, which is considered potentially slightly more effective but more aggressive treatment. The other approach that we have taken to assess the efficacy of these treatments is to do simulation studies. And for this, we're using a simulation, a mathematical model of lung cancer that is being developed by Dr. Cohn, which is a faculty here, but developed this when he was at Mass General. And it's a really sophisticated model of diagnosis, progression, and treatment of lung cancer. And each of these components blows up into like a lot of details about the trajectory of these patients. And this clearly has there's some noise, sorry, does that mean? Okay. Seems to, there's the benefits that you can really do, generate a lot of patients and evaluate very personalized approaches, but obviously the limitation is that this is all based on, a mathematical model that has multiple assumptions. So we got funding from NCI to assess try to find what is the optimal treatment for patients with comorbidities. In this case, we look at CAD, CHF, kidney disease, and COPD, and the combinations of those. And this is because in this patient, the trade-off is like more aggressive treatments like, full resection are associated with increased risk of immediate adverse events, but decreased risk of long-term recurrence. But the question is, some of these patients may not live long enough to experience a recurrence. So what is the trade-off between these two forces? And here we simulated a wide range of patient ages, sex, tumor sizes, and comorbidities. And you can see that for most of the combinations, the preferred treatment is either lobectomy alone or lobectomy as segmentectomy, where, SBRT in the lighter gray color is only an option, an equivalent option for the oldest patients, particularly in older male patients. So this data tells you, how even among patients that are older and had multiple comorbidities, more aggressive treatments seem to be leading to better outcomes compared to, SBRT or more limited resection. Now, there's limitations on all these approaches that I show you, and so there's a last potential approach that you can use to address them, which is called instrumental variable analysis. And this is the approach that gives you the evidence that is closer to an RCT using observational data. And how this is work. In this study, for example, I'm going to show you, we're trying to look at the association between radiation therapy and improvement in survival in patients with early-stage lung cancer. The problem is that they are omitted covariates. So the propensity score allows you to adjust for everything that you measure, but there may still be other factors that you cannot measure that may be associated with the use of radiation therapy and survival, and therefore confound the relationship. Some patients do better, not because they got RT, but because they had this omitted covariate. So the way to deal with this is to use what is called an instrumental variable. This comes from econometrics. That is a variable that is associated with the exposure of interest, treatment in this case, but not associated with the covariates or survival. What is an example for this? In this study, and so therefore, you can track back through the instrumental variable to survival, you can rescue the effect of radiation therapy. In this case, and I'm going to show you two examples. In the first case, we use geographic area. We do know that in the United States, there are different patterns of care. So some areas that use more of a treatment or of an intervention than others. And if we find large enough areas that are relatively homogeneous in terms of everything else, but that reflect different patterns of care, this shift in treatment from one area of low utilization of radiation to an area of high utilization can allow you to rescue these marginal patients. That is, I think, Andrew, you are coming across. I don't know, you seem muted, but anyway, as assess the effect of radiation therapy. And so this is what we did in this study, and this was the first study using around 6,000 patients that really compared use of radiation versus no treatment for early stage disease. And using this approach, we found that compared to what we call a naive approach, an adjusted approach, which showed that radiation therapy was associated with approximately a 15% improvement in 1 year survival. This instrumental variable approach gives you a more unbiased estimate of only 10% improving survival in lung cancer in patients treated with radiation therapy. And this includes adjusting for measured and unmeasured confounders. The second example that we used was tumor laterality. In this case, we were trying to assess whether radiation therapy of the chest is associated with increased risk of cardiovascular disease. And we compared two treatment strategies, the more modern SBRT and the prior standard, which is 3D plus IMRT. And the issue is here that the assumption here is that whether you have a left or right tumor, it is associated with the exposure of the heart to radiation. Obviously, if you have a left tumor, you're going to get more radiation to the heart. But whether you have a left or right tumor should not be associated with your, baseline characteristics or your likelihood of receiving, or not receiving radiation therapy. And when we compare, overall, left versus right side tumors among those treated with SBRT, we find no significant difference in any cardiovascular disease-free survival, both for SBRT and 3DRT. However, when we look at individual cardiovascular adverse events, both congestive heart failure and the need for percutaneous coronary interventions among patients treated with IMR, 3DRT were significantly higher, suggesting that not SBRT, but traditional T may be associated with increased risk of cardiovascular toxicity, and these patients may require either more intensive follow-up or more aggressive management. The last issue I want to touch base on is the issue of equity access to screening and treatment. And we know, unfortunately, there's significant disparities in lung cancer outcome in the US, with both Hispanics and Blacks having increased mortality and higher likelihood to be diagnosed with distance compared to localized disease. And even as we are early in the phase of implementation of screening, there are studies already showing that Black patients are 5 to 10% less likely to receive screening compared to whites. And likely this is multifactorial, but let me share with you some of potential things that we unveil. This was an early study we looked at here in IMA, looking at beliefs about screening among minorities versus non-minority patients. And you can see here that both Black and Hispanics were more likely to hold different beliefs about cancer itself, being more confusing, thinking that microwave waves can cause cancer, or having more views that lung cancer may be something that is meant to be, and also they were likely to hold beliefs about screening itself, being more concerned about radiation causing cancer, or CT scared them and stuff like that. So clearly show differences in how different groups approach lung cancer itself and screening, and how the messages as the education about screening needs to address these differences in order to ensure that everybody has equitable access to screening. Additional work was done by Mina Kale at our division, and she looked at the match between accessibility to screening in terms of presence of lung cancer screening centers and where the patients with lung cancer reside. And what she found in this kind of cluster analysis that she did for data across the US was that there was huge heterogeneity, and there were many areas where there was a lot of lung cancer patients, but very few centers, particularly in the southeast of the United States. And interestingly, some of these areas, both here in the southeast and in California, that have low density of lung cancer screening facility is where most of the minority patients with lung cancer reside. Again, suggesting another potential barrier to equitable implementation of screening. Unfortunately, there is also disparities in the treatment for lung cancer. This is data from now close to 20 years ago, Peter Bach at Memorial then, published in the New England, showing that white patients with early stage disease have better survival than Black patients. And we published in the Blue Journal similar data comparing white and Hispanics using the SEER registry. And we both also show that once you adjust for treatment, these disparities in survival go away, suggesting that inequities in treatments are driving these disparities in outcomes. And more recently, we published a paper in CHEST showing that this was also true among patients participating in the NLST, where Black men patients with early stage disease diagnosed by screening were less likely to receive surgery. And remember, these are patients that are motivated enough to sign up for a screening study and undergo screening, suggesting how deep these problems are. And unfortunately, this data from Andrea Wolf, again here at Sinai, which she looked at trends, compare patterns of treatment in 2 different decades, and there was been a lot of dissemination of these disparities during this period of time. And unfortunately, if you look at early stage disease, both in the 1990s and the 2000s, Black patients were less likely to get treatment compared to whites and less likely to get surgery, more likely to be treated with radiation alone, showing that, again, these treatments have been persisted over time. So I want to share two other studies that we did that may address the issue, or are we as physicians contributing to this problem? And there's been, proposed that issues as, cognitive processing, uncertainty, and potential some implicit bias may play a role. So in the study that I mentioned to you about SBRT versus sublobar resection, we also interviewed the providers. And before they treat each patient, we ask them, about the characteristics of the patient. And in particular, we ask them to give us an estimate of what percentage of the patients that look like this patient will undergo resection, and what they thought the probability of this individual patient was to undergo resection would be equivalent to a propensity score. And we compare that to a model-based estimate of the probability of this patient to undergoing resection, meaning that would be kind of more than unbiased probability of this patient based on their characteristics to undergo resection. And here is the percentage of patients that were percentage of patients that were considered to be good candidates for resection, based on the report of the doctor in pink of how many patients like that they will think that they will receive resection, their estimated probability that they will undergo resection, and the model true base of their probability. And it's what we found interesting is for the entire cohort, doctors were more likely to think that white patients were candidates for resection compared to what was estimated from the model. But for Blacks and Hispanics, they were equally likely, suggesting actually that the bias was not against minorities, but actually in this case was that they were overestimating the probability of whites to undergo resection. However, when we look at the patients who undergo radiation therapy, specifically a subgroup, the patterns were even more striking. Look, here, among patients who undergo SBRT, providers were estimating over 15 points greater chance of that patient to undergo surgery compared to what the model did. And conversely, for Black and Hispanic patients, the model were estimating a higher probability that the patient would be a candidate for resection compared to what the estimates were given by the doctors. Again, showing you that some potential cognitive processes in assessing the likelihood that the patient could be a candidate for resection may be influencing the actual disparities in the management of these patients. The second study that we looked at potential physician biases is in this study that we did with the National Registry. So here we look at 20,000 patients, Black and white patients, that had a visit to a surgeon within 3 months of the diagnosis of lung cancer. And we wanted to see whether there are different patterns in the way that patients were treated by surgeons. And here you can envision 4 different scenarios. If this is the probability of patients being resected, again, they saw the surgeon, but some of them end up being operated, some didn't. You can hit a situation where there's no disparities and not heterogeneity in the doctors in terms of the number of patients that they resect. So, for example, if these in pink are the white patients, in white are the Black patients, most of these doctors have an similar rate of the number of patients being resected, and this is balanced for Black and white patients. Here will be an example of how things look if there were no disparities but heterogeneity. So here, as you see, some doctors that operate only 50% of their patients, some doctors that operate most of their patients, but the rates of white and Black patients that they operate is equivalent. So there's differences across doctors, heterogeneity, but no disparities. In this case, you have disparities, but not heterogeneity. Most doctors operate the same rate of patients, but they systematically operate more white than Black patients. Okay? And this final pattern, you have you have heterogeneity in disparities. So you have heterogeneity in treatment. Some doctors operate more than others, but also you have heterogeneity in disparities. Some doctors treat equally likely Black and white patients, but some doctors have a lot of disparities and some doctors have much less gaps. Again, you will see some random variability in all these things, but with a statistical model, you can test which one of these patterns is the one reflected on the data beyond chance. And what we found is, first, among patients with early stage lung cancer that saw a surgeon within 3 months of surgery, Blacks were 40% less likely to undergo resection. Already a big disparity there. And again, even among patients that that have Medicare insurance and that saw a doctor, a surgeon. Second, we saw the significant heterogeneity among doctors. Some doctors operate a lot of patients, whereas some others operate much fewer. Finally, we saw a significant interaction in heterogeneity with race, suggesting the fourth scenario where for some doctors, there is minimal disparities, but for some doctors, there are huge disparities between Black and whites. Again, suggesting that here may be a physician component operating. Finally, we saw that when patients were seen by a general surgeon, there was huge disparities in care. When patients were seen by a thoracic surgeon, there were still disparities that are much more attenuated, suggesting that those who may have better knowledge about the management of the disease, there would be less uncertainty and potential less disparities in care. Let me spend 3 more minutes about how we can address these problems and show you 3 examples. This was randomized trial conducted in a community center where they randomized patients to a navigator for screening versus usual care. And what they found is that if you have a person that helps with shared decision-making, with schedule appointments and overcome barriers, and this was conducted among particular minority populations, there is the increased rates of screening among those who get support. The second approach has been using a band in rural areas. And this study in North Carolina, where they sent a band to different community centers to promote screening. And they did this for 550 individuals, mainly rural and minorities, and show that, deploying this band, you can get similar outcomes compared to the NLST. And finally, an intervention that was done in a 5-network group in North Carolina that showed that intervention, including warning of unmet stones, meaning a patient didn't show up to the surgeon or didn't get like a PET scan, feedback to doctors regarding how many of the Black versus white patients get treatment, and then patient navigation was associated with increased odds of resection, timely resection among minorities. So let me stop here. Sorry, I'm running a bit late because of the technical issues that we faced, but hopefully I made an argument that we need to increase the focus on early stage lung cancer. That focusing on stage 4 disease is not going to get us what we want. And particularly now with screening, we expect that around 50% of the patients will have early disease. So we need better data in terms of who should be a candidate for screening and how to treat these patients to ensure equitable and good access. So just sorry, briefly, but mention that, this is really a huge collaborative effort with many investigators in Sinai and other groups, and obviously, supported by multiple funders. So I will stop here and maybe we have time for one question.
Thanks, Juan. That was great to see your body of work on this. It's really terrific stuff. I'm sorry about technical difficulties, not sure. And everyone was muted too, and I was checking it, but everyone was muted and it was still coming through. I know that Dr. Kraft has a question.
Really quick. Yes, really quick, because I know we're ending. And this actually isn't necessarily entirely on your topic, but you made a mention, by the way, the talk was very comprehensive, really helpful. Thank you so much. You had mentioned early on that outcomes were better in women for lung cancer overall. Now and we know lung cancer is very heterogeneous. Now that we have some immunotherapy for stage 4 non-small cell lung cancer, which is a real advance, because generally you're right, by the time we get to stage 4, there weren't a lot of options. And still you could argue there are some, but we have a ways to go. I don't know if you have data, and this may be out of the scope of your talk, on gender specific responses to immunotherapy in non-small cell?
Yeah, they are, and actually Raj Velaswamy, which is a faculty here, and I saw Tom Moran. I don't know if he's still around. They are experts on that, and there are significant differences in the response by sex, and Raj had a very interesting proposal to try to understand whether these were mediated by hormonal differences, or a difference in the tumor burden, or the inflammatory responses, but clearly a potential. Unfortunately, he submitted a case that never got enough good score to go do that work, but he has moved on to do really other great funded works. But definitely some area for there. I think there's and actually. Charles Powell had his early career was dedicated to the risk of lung cancer in women versus men, and different susceptibility to smoking. So I think that's really a very, very interesting area.
Sure, great, thank you. Thanks so much.
Great one. There is, Andy, you just put a question in. Thanks for the great talk. Andy Dunn says, good to see that study showing that alerting practice to disparities can help mitigate some of the differences. Yeah, again, that's, I think, a great comment, Andy. Thank you. So I think for interested time, Juan, really wanted to thank you for presenting your work. Just really a terrific body of work. And thanks so much for representing the division, which I am a member of, and the department so well. So thanks a lot. Have a good day, everybody. Appreciate you all for coming. Take it easy.
Bye now.
See you, Juan.